Oh, good afternoon, everyone. I'm so glad to be back here in Denver for CVI 2019, and thank you, Paul, for inviting me back again. This topic talk is transcatheter treatment of residual MR, which is a broad topic. So I'm going to talk about mitral PBL closure. These are my disclosures, and I think I'll have 3 key points for you. The first is why PBL after mitral valve replacement is so pesky and a real problem for cardiac surgeons. And I will review the comparative outcomes of reoperation versus transcatheter closure. And finally, a couple technique points for transapical percutaneous closure of PBL. So why don't we start with this case. This is a 79-year-old female, shortness of breath. She's got comorbidities that make her high risk. And she had an echocardiogram that showed both moderate MS and moderate MR, which we thought was worse. And unfortunately, at that time, we didn't know that Paul was enrolling in the Tendyne TMVR for MAC trial. And here you can see an echocardiogram with the MS-MR with severe, I think JO would call this class 3 MAC, 207 degrees of MAC on the fluoroscopy. So she was symptomatic, bit the bullet and operated on this lady. And I thought, got a pretty good result here. And the tough part about seeding this valve is you can't really take out all the MAC without rupturing the heart, yet if you don't take out enough MAC, you can't get a big enough valve. And you see I've got the smallest bioprosthetic valve in here. And I put a felt strip between the sewing cuff and the MAC, and I thought I had a pretty good result. The intraoperative echocardiogram shows mild PBL. And for me and my residents, I tell my residents you can't leave with any PBL because your cardiologist won't like it, first of all. And the second thing is you can get hemolysis from these small ones. But for this one, I didn't really see any other way to get that thing out. We're off pump and there's no rupture, so I was actually pretty happy, like high fives. Mild PBL, we're out of there. Of course, 6 months later, this TE was done to evaluate for hemolysis, and you see that the mild PBL is maybe moderate. And they sent this patient back to me, and my first reaction is to deny that the hemolysis is from this PBL. But finally, you know, the patient's getting iron transfusions regularly. She's not feeling good. So we've got to do something. Okay, so PBL after MVR, the reported incidence is about 2 to 17%. About 3% of these cases will need to get re-opt, and not just for the PBL causing heart failure, but for PBL that causes hemolysis. And the risk factors for PBL after mitral valve replacement are as follows. The friable annulus, so MAC, is definitely at the top of the list. Endocarditis is there, connective tissue disorder. Patients who've had multiple previous cardiac operations is a risk factor for PBL, and surgical technique. This is one key slide for you summarizing the guidelines for treatment of perivalvular regurgitation. I summarized it for you. So I'll point out that it's a class 1 recommendation to re-op for a couple reasons. So Americans cite, if you've got a mechanical valve in there, you're probably thinking about a reoperation because the plugs that we put in, and I'll show you in a little bit, can interfere with the mechanical valve function. And the Europeans point out that if it's PBL because of endocarditis, it makes sense that should probably go to reoperation. And it's a class 2 recommendation to do a percutaneous or transcatheter closure repair only for high-risk patients. But in reality, most of these patients are high risk. So when I see PBLs after mitral valve replacements, I first think transcatheter replacements. And there's a couple reasons for this. The outcomes after reoperation is not very good. This is operative mortality of 6 to 22%. So this is definitely not a low-risk procedure. And the other big bugaboo is that although we can get a pretty good repair at that time, these things tend to recur. So this is very frustrating for the patient to have one mitral valve replacement, two re-op for a leak, and then 5 years later, the quoted incidence of recurrence is about 10 to 15%. So this is a problem for us. On the other hand, transcatheter closure, the risk profile is pretty low. So 1.7% risk of perioperative mortality. It's really good compared to what you see for surgery. The success rate is a little bit lower, quoted 70 to 95%. Survival is never really good for these types of patients. It's probably more with the disease process than the fact they've got PBL. So this is a good paper. I didn't check, but Dr. Elliott is probably on this one, right? As well as Paul should be on this, but Paul had left at that time. Comparing transcatheter and surgical management of mitral PBL. And the take-home point is surgery is more successful, but at a cost of perioperative safety. This is what we would expect. So what do we do for this patient? So after we decided to treat this patient, we measured the defect first of all, and I asked Charlie Davidson and Mark Ricciardi to do a transeptal approach. Just like crossing my fingers that I would never hear back again from this. But they unable to cross it. Multiple wires, just was not able to cross it. You got a sewing cuff and some Teflon felt there. It's a serpiginous tract, so what are we gonna do now? So I really didn't want to re-op this patient. So Charlie and I did, with Mark's help, a transapical percutaneous closure, and the first imaging here is the TEE, and you can see that the leak is right around the 5 to 6 o'clock position, so around the P2 segment, which is a common place for this to happen. We punctured the apex percutaneous with a 5 French sheath. After probably about 30 minutes to an hour, was able to get the wire across with a long sheath across. And the device we use is an Amplatzer Vascular Plug 2. And when I looked at Paul's series, I think 70% of the PBL closures, he used the AVP2. And I have to tell you that this is an off-label use of the Vascular Plug. There's only one commercially available plug for mitral valve leak, and that's called the Occlutech. I think someone presented that, but it's not available in the United States. We decided to put a second device in here because you really want to get rid of this leak, because if you leave a residual leak, maybe the hemolysis doesn't go away, and we don't want to be back here puncturing the heart for a second time. So the second device here, we used a buddy wire, held on to the first AVP2 and placed the second AVP2 a little bit bigger. So the closure of the apex. I think some operators have tried to just leave the 5 French hole alone, but reading through the literature, that requires a lot of postoperative surveillance, as often as 15-minute echocardiograms for the first couple hours. That will definitely drain your resources. So instead of doing that, we decided to close this apical puncture. And again, this is an off-label use of an Amplatzer duct occluder. And the typical size is the 6x4. And I think 90% of the cases that are reported use this particular device, the ADO 6.4. And one more caveat I will tell you, that with these long procedures, there is a little bit of leak around the apex, and it doesn't leak out of the chest. You don't see it on the table, but it does leak in the left pleural cavity, and this is not a big deal to put a chest tube in at the completion of the case. And most importantly, pretty much no MR, no hemolysis for this patient. Key points for this, for you, And your practice, PBL after mitral valve replacement occurs 2 to 17%. We have to operate on 3% of them. The risk factors are what you would expect: MAC, endocarditis, previous cardiac surgery. In my mind, and I think for most cardiac surgeons, transcatheter closure is the preferred option by transeptal approach. And for me, if transeptal approach is not an option, I really like this case that we did with Charlie and Mark, because otherwise I'd have to re-op that lady, and that would turn out to be a successful case. A transapical approach, percutaneous, can be done and has been reported. These are the references I think you could pull from the app, if you've got the app downloaded, if you decide to take on this sort of case. Thank you very much for your attention.